very sensitive test and is highly predictive of outcome. There's largely data from one lab, which is the clonoSEQ. So this is the last slide. If you ask me, myeloma for genomics is genomics for myeloma is very much like Lord of the Rings. This is the Isildur's bane, and the promise is that there is one NGS assay which can detect all these abnormalities. The disadvantages are, number one, it's not very cheap, but sequencing costs are reduced. It's just like any other myeloid panel, you can get this done. It is not suitable for small sequencers. Results take time. There is significant computational expertise that is required for these tests. So with that, I'd like to say thank you.
Thank you, Nikhil. So before we wind up, any burning questions you have? Yeah, please.
Hi, Srijesh.
Do you sort? Do you
always? So anything you want to do with myeloma, you have to enrich. So we either sort or you have to enrich through magnetic beads or what have you. You need enrichment. Otherwise, all of these abnormalities get masked.
So how do you get the first sample goes for fish and?
If query myeloma, we sort.
No. Which sample do you get for NGS?
Bone marrow.
No, sir. I mean, the first sample most likely goes for fish.
Okay. Whether it's first pull or not. So this is done on a side business kind of thing. So most likely fourth, fifth pull. Arey, wo usko bhi ek bhej do tube. That sort of thing.
Yeah. Nikhil, great talk. I just have a question. Like for 1P, 1Q, which are secondary abnormalities and could be in a small subset, So what is, have you done, what is the sensitivity till, especially for the copy number?
So we haven't
How
done,
low can you
but
go
this
for
is
that?
a very valid question, and this is an open challenge in the field. Right now, copy number alterations can be detected only up to a limit of 20% when you want to do this, when you want to do depth of coverage based analysis. However, the B allelic fraction that we have described here can detect copy number alterations as low as up to 0.5%. They are called as CMCA. You must have seen this in multiple papers. They are called as mosaic chromosomal abnormalities, and they are detected based on B allelic fraction up to 0.5. We haven't done that sort of testing. I don't think we are there yet.
Sure. Great.
Thank you. Nikita, the last question.
A wonderful presentation, and Patkarji, nice to see you in a myeloma conference also. So essentially, if I can quickly add, this plasma-seq, which has been developed by a group, Nikhil Munshi sir is a part, and it is now available in India as well. And of course, we were in discussion with them, and they've also got a version 2.0 now, which is really quite cool. And sir asked a question on sample, that the amount of sample that's required is so little. I mean, I don't know, of course, you all will have to decide as to what goes first. The clinicians have to decide, fish or NGS. But exciting times ahead.
There are several groups that have described, consortia have described ways to get together and address this myeloma business. Yeah, I mean, if it works for fish, it will work for this as well. I don't think sample is so much of a problem.
Thank you. Yeah. So now I hand over to Jeevan.
So Nupur will have some announcements.
So as we come to the end for today, I would like to thank all the speakers for their expertise and significantly impacting today's event. This will be followed by dinner on the ground floor in the dining area. Good night. See you all tomorrow. Sorry, the dinner is on the first floor. In the physician's cafeteria.
common bacterial infections in myeloma because of the way the infection depends highly on pneumococcal antibodies. So it's recommended that all patients at diagnosis get the pneumococcal vaccine. And it's important that you have enough time to do this because it's two different vaccines separated by time. So if you are vaccine naive, the first thing you should give is the conjugate vaccine, which is PCV13. It's much more immunogenic than the polysaccharide vaccine. And once you're primed with that, you follow up with the 23-valent polysaccharide vaccine. This has less immunogenic, but it has more serotypes. So you really need at least 8 weeks to get both of those in. And then shingles. Last year when I was here, the shingles vaccine had just recently been introduced in India. The shingles vaccine is an inactivated vaccine, so it's completely safe for immunosuppressed patients. It is also a two-dose series, and again, very highly effective in immunocompetent patients. It's about 98% efficacious. In myeloma patients, it will be a little less, will have less efficacy, but still a very good and safe vaccine. Similarly, we have now an Indian version of the post-BMT vaccination schedule. Typically, you start vaccinating 3 to 6 months after transplant, and there's a whole series of vaccines that you need. I won't go over this in detail, but it's exciting that you now have Indian recommendations. The other thing that often gets forgotten is vaccination of contacts. So as we know, myeloma patients don't always react adequately to vaccinations. Adding vaccination of their contacts is another layer of protection you can give your patients. So everyone in the household should also receive vaccines for especially pneumococcal vaccine and the flu vaccine. Most adult pneumococcal infections actually come from children in the household, so getting them vaccinated is important. Similarly, another question that I get asked even today is it okay for household members to get live vaccines? And it is. So chickenpox, MMR vaccines don't really, the vaccine virus, although they're live vaccines, don't transmit. And so it's very safe and very important that household contacts get vaccinated. And similarly, one of the contacts of myeloma patients is healthcare workers. So it's very important that healthcare workers get the flu vaccine. Tdap also is very important because you're not vaccinating for tetanus, you're vaccinating for pertussis, which is highly communicable. So I've tried to make a case that vaccines save lives, but actually it isn't true that vaccines save lives. It's really vaccination save lives. One of our previous speakers was talking about when patients come to him as a nephrologist, needle Gusega. And I want you all to say, when I see my patient, needle Gusega, because it's really the needle going into patients that will make a difference. Just having vaccines without providing the vaccine to the patient will not work. So when they come to infectious disease, also needle Gusega. And this is so important. This is a study that from Mike Thompson, who looked at vaccination rates in a myeloma trial. And he reported that vaccinations actually were associated with better survival, but look at the vaccination rates. This is across the board. They look at multiple different regions, and every region was quite bad. The US was better than most regions, but you can see the vaccination rate. The red line here is the flu vaccine, and the black line is the pneumococcal vaccine. And you see that rates are very, very low. So very quickly, prophylaxis. Dr. Raje, who was the previous speaker, has published, was the lead author on a publication on guidelines and recommendations for infection prevention in multiple myeloma. And I have just one slide that is going to talk about all the different recommendations, and then I'll sort of give you my take. Sorry, Nupur. But essentially what they have recommended is that you classify patients by low risk, intermediate risk, and high risk. In low risk, you may not need any prophylaxis at all. I think that my take is that you probably should give pneumocystis prophylaxis, because most of these patients, even though they're low risk for infection, will be getting steroids. So that's one slight change I would recommend. For patients who are intermediate risk, it's important that you give pneumocystis prophylaxis and, in addition, antiviral prophylaxis to prophylax against HSV and HCV. You could consider levofloxacin prophylaxis. I know that in the Indian context, that may or may not work, simply because of your antimicrobial susceptibility patterns here. And then for higher risk, you should consider, and I'll say antibiotic prophylaxis, whatever the agent you use. Give prophylaxis against viral infections. If patients are neutropenic for a long time, you may need to consider additional prophylaxis like fluconazole if you're worried about mucositis, or something like itraconazole if you're considering other fungal infections like aspergillus. And one thing that I was trying to find is really the epidemiology of infections in India and in myeloma patients, and there's very little data. So as you all are working, it might be important to find out what infections you are having, what infections you're encountering. I know that many of you have registries, and finding that out could really inform what sort of prophylaxis you do in India. Prophylaxis is a double-edged sword, as you know, because antimicrobial resistant rates are so high, you just keep shifting infections if you don't do prophylaxis correctly. So that's all I had. I think I finished right on time, so I'm happy to take any questions.
Thank you, Dr. Priya. Any questions for her? Yeah. The needle man.
Ma'am, I have got one question. What is the dosage schedule for hepatitis B you use in myeloma patients who are immunosuppressed?
So what we, so for vaccination?
Yeah, perfect.
So for vaccination, we have really moved to using Heplisav in the US. I don't think it's available yet in India. So we, it's a 2-dose series. It's highly immunogenic. And so dialysis patients, non-dialysis patients, all of them get Heplisav. I would treat a myeloma patient like a dialysis patient and give them the higher dose of hepatitis B. You have the dialysis formulation, right? So like the renal failure dialysis patients, I would recommend using that for myeloma patients also.
My second question is, you didn't talk about Clostridium difficile. The incidence of Clostridium difficile is very high in immunosuppressed patients. So what's your take on that, ma'am?
So there is no real preventive for Clostridium difficile, which is why I didn't talk about it. We don't have an effective vaccine for Clostridium difficile either. The way you prevent C. diff is really using antibiotics wisely, hand hygiene, preventing transmission between patients. And that's why I think it's very important that you understand what types of infections are occurring in your patients so you can use your antibiotic prophylaxis wisely. Otherwise, you'll use an agent like levofloxacin. In the Indian context, most patients will not be susceptible to have bugs that are susceptible to levofloxacin, and the risk of C. diff is very high with that agent. So
I think there's a trial of vaccine going on in the US.
there is it's in phase 2, so nowhere near prime time, nowhere near ready for use.
Thank you, Dr. Priya. With that, let me call on to the last speaker of this session, Dr. Rimpa. And she's going to talk about, is there a role of radiotherapy in the current management of multiple myeloma?
So good afternoon, ladies and gentlemen. And at the outset, I would like to really thank, of course, my home organizers, but Dr. Raje, who just left after a long day, for setting the tone and the ethos for the proper utilization of a service is what is important. You know, as a strong team of radiation oncologists, especially in the arena of hemato-oncology, it is important that the team of radiation oncologists integrates the biology of evolving treatments or radiation and its damage into decision making. And it's actually a bigger art to say no for these indications rather than to say yes whenever there is a referral. And both my teachers here, Dr. Reena, Dr. Chandy, and all my colleagues in the hematology department will tell you that of our utilization of a positive decision to use radiation oncology in the management or the combined modality is just about 10 to 12% in the hospital. And there's a reason for that. And this audience does not need to be taught those reasons. And I tweaked the topic of my discussions to, is there a role of radiotherapy, to how do we integrate radiation therapy in the contemporary management of multiple myeloma in the era of biologics and novel treatment. What are the indications? The indications are now very niche because the bone marrow must be looked at an organ at risk, and therefore how do we select doses or rather personalized decisions? A very quick and a small case to begin with. 50-year-old gentleman coming from a very low socioeconomic background, revised ISS staging 2, ECOG 4, severe pain as is very obvious. His living is by farming. That needs quick recovery as his treatment goes on. From the portal that you see, we decided that we would treat him with radiation therapy after adequate analgesia failed, and our margins are actually very small. We hardly ever use large field radiation therapy, and when we use low to moderate doses because we need to be very cautious to say yes, and of course to decide on the marrow reserves of a patient. This is a young man, and irrespective, let us put his socioeconomic background in the back burner and just talk of biologics and science. He finished his radiation therapy, and we often encounter and deliver radiation therapy in combinations of novel agents and combination therapies. So we need to be very, very cognizant of that fact. 3 months down the line, all of you know that radiation therapy has excellent pain efficacy, and that is what we saw. Despite him being a risk stratification adapted staging of 2, after 7 cycles of combination and bone-directed agents, during the 8th cycle of VRD, he did complain of some pain, and then very quickly he came back to the emergency 3 weeks after his OPD encounter with this. I don't think I need to spend time describing that this is a local bone complication with a possibility of a poor neurological outcome. This is a young patient, short duration neurodeficit with a sensory level. We did not go ahead and deliver radiation therapy upfront. He was taken for decompression, and his systemic treatment was changed to a newer agent. However, he persisted to have bone pain at the local site, which we know happens in about 50% of the patients who've undergone a spinal stabilization, some amount of lung changes. Again, we had to come in with some radiation therapy. Mind you, the equivalent biological doses of radiation therapy, in contrast to earlier teaching of higher doses, larger fractions, excessive volumes, are now very low. So that is how we try and personalize, and very well tuned to the current ethos of the International Myeloma Working Group of bone marrow and its reserves. To be radiation oncologists need to be cognizant of marrow reserves because these patients now live extremely long. But again, just to illustrate efficacy, that's just a screenshot from the nursing assessment on his subsequent admission for biologics, and there is complete relief of pain. There is some neurological recovery, which of course takes a long time, and very active physiotherapy is extremely important. However, there are many kinds of lesions and referrals that we encounter as radiation oncologists. 80% of these patients get referred to us, but like I said, our decision-making to utilize and deliver radiation therapy, Dr. Reena and Dr. Chandy and all my colleagues, Debranjani, Surely all of you who are here will agree that we hardly ever agree to deliver radiation therapy when a patient is treatment naive, unless absolutely indicated. This is from the last few images of the patients that we've encountered. Patients in severe pain, patients in lesions in eloquent cortex with impending visual losses, relapse refractory disease in elderly individuals with severe bone pains, epidural spinal cord compressions, and severe pain at weight-bearing areas in ongoing treatment patients. So there are very, very highly selected indications, and very gradually, these older indications are taking a back seat. I wouldn't say a back seat. They remain as they are with de-escalation and personalization of care. But as we go through the presentation over the next 2-3 minutes, you will see that we will soon find and think about newer indications. And that is why I thought I would put this. As radiation oncologists in the hematology group, it is important to understand systemic treatment. We just can't be a technician at our job that you've been given a referral, go come in, say yes, treat the patient and go. Especially in the contemporary management of excellent analgesia, there are few indications of radiation oncology, and they are important indications not only for control of pain, but we see in the next few slides as emerging newer indications. That's a little word cloud, and I think the most important thing there is not radiation therapy, but radiation therapy in context of decision-making of the bone marrow reserves that a patient has. And we get a more or less an idea from a lot of functional imaging that goes in inside our disease management group. All patients get evaluated with MR imaging. And we do like a lot of MR because even when I'm voluming these lesions, I look at the marrow reserves, not that you will see the functionality of marrow, but you can get an idea on the bone marrow edema from these scans. And we move into various, the sequences of the MR. And why I say, as a radiation oncologist in a podium, that do less and less of radiation therapy, do good pain control, start your biologics as combined treatments early on, and take decisions as you go along. On the right-hand side, I show you a long-term follow-up MR scan of one of our patients of anaplastic ependymoma. You can see that lesion out there. Treated when we just began the hospital in 2011. She's luckily still alive, despite this being an anaplastic, and we've proven that by methylation studies. And look at the marrow, the entire marrow segment, which has been radiated as a, it's a bystander effect of trying to give her survival with good radiation therapy for ependymoma. The entire marrow segment in that upper cervicodorsal spine is replaced by fat. And we don't want large marrow volumes. And now that this hospital, or as we see longer follow-up of patients, we must be cognizant that marrow should be recognized as an individual organ at risk, and it must be respected. Is radiation therapy safe with concurrent biologicals or novel agents is the next question. The first question was asked in 2014, and there is enough data from retrospective and then prospective studies to show beyond doubt that radiation therapy, when used in the setting of myeloma, does help. The reason is very simple. Myeloma stem cells, which are mature B cells, are exquisitely radiosensitive as their radiobiology. And therefore, it's no surprise to see good drops in M protein. But currently, that is not a feather on the cap because you have competing biologicals which will achieve better drops and will protect the marrow for future transplants. But it is safe. To answer the question, young fellows often ask me, Ma'am, can we do this with Carfil? Can we do this with BORT? Yes, you can. But whether you should do that is the first question. So decision making is of extreme importance. So biologics, novel agents have drastically improved myeloma survivals, and this is not an audience on whom I'm going to waste time trying to show you the curves from Fonseca, first presented 2017 Celgene conference, and we know how beautifully survivals of multiple myeloma have been increasing. This is a paper from the Netherlands group. I'm sure all of you have read it. And the question was being discussed in the previous session about transplants as to whether we achieve a good partial response in a patient and then take the patient for transplant. And I think these are the newer thoughts into which a radiation oncologist and their team must integrate. And if you look at the overall analysis, this is a pure biologics paper for a tandem transplant. I'm sure most of you have read it. It's very strong data from the Netherlands, published 2 weeks ago. If you look at their entire cohort, good transplant, again, giving excellent survivals. You don't want these patients who will now go on to live long with single or multiple transplants to have their bone marrows knocked out with large volumes of radiation therapy. So I am a radiation oncologist at heart, and therefore we want our patients to be, treated for the best niche and the most biological indications, because radiation therapy has two elements when we integrate in hematology. It not only kicks the local immune system to a certain extent, and we have information on that from very recent data on bridging therapy with radiation, low-dose radiation in the setting of CAR in myelomas, and radiation in hematological malignancies, irrespective of diagnosis, also has an extended Goldie-Coldman hypothesis for certain solitary refractory lesions, entire marrow in remission, M proteins down but stuck at a level, but you still have something producing the myeloma protein. It's probably needing a non-cross-reacting agent if you've used the entire, the battalion of the biologics and the immunotherapy agents that we now use. And so these are the lesion encounters, but how do we personalize? I mean, do I say no to every patient? Of course not. Because in this part of the world, apart from understanding a lot of good science, we must understand as treating teams that to say no by adopting direct evidence is easy, provided I can use the agent which achieves that equal amount of remission. So extending and adopting levels of evidence needs certain amount of tweaking in our parts of the world, in our practice, across various socioeconomic strata. We have families who donate accelerators to us, and we have families for whom we arrange where the next meal is going to come from. So our personalizing of decisions of radiation therapy in a multidisciplinary team meeting is of extreme importance. However, at Tata Medical Center, we do have a structure. We say no to most patients because we know that most patients will have uncomplicated bone lesions. So we will take proper decisions in events of complication, which are, I'm done, just another one slide. And we look at the complication levels of the lesion. But what is most important, most of our patients are for pain control. And only when all the answer here is a big no, or you are looking at a very small volume and a quick treatment, we come in with low doses of radiation therapy. And my current colleagues in the audience will tell you they hardly ever see any high dose radiation therapy in our hospital. Most of it is very, very low dose of radiation therapy, well reflected from our ILROG papers that are now published, led by my friend Leslie Ballas. And we are now looking at very, very low doses of radiation therapy because myelomas are exquisitely radiosensitive. New niche, yes, please give it a thought. Bridging radiotherapy for certain lesions seem effective. I am not saying use it. I am saying being cognizant of a biological signal here. Till the time that you are re-engineering the CAR-T, if a patient has a solitary lesion that is documented, instead of maybe coming with loading patients with refractory biologic, maybe we could come in with very low doses of radiation therapy to a marrow-adapted volume. And the same signal from this paper from John Plasteras and his team. It is safe, of course, but that is not the message that we wish to convey in this meeting. As a team from Tata Medical Center representing the usual mandate of a multidisciplinary team, we may give it a thought about bridging, and that is why we are really, really looking forward to commissioning and taking the first CAR patients as soon as possible, whenever that is. So to summarize, biologics has significantly improved, and I don't think I need to reiterate. It is a diagnosis, it is a chronic illness now. From deaths, we have moved on to chronic illness, and therefore, we must respect organs at risk. It remains a very highly effective and safe palliative treatment for pain control or for complications. However, consideration must be given for potential hematological toxicity, and do not forget marrow reserves as a caution. We saw definitions of dose escalation and a framework for personalizing radiation therapy, but what we as a team here are more interested is to understand how we can scientifically and biologically integrate ourselves to bridge patients as they wait for engineering of their CAR. There are no consensus guidelines yet as to which patients should receive, and these are most often team discussions and decisions. Bulky disease, oligoresidual disease, if there is a concept at all, limited disease, locally rapidly progressive symptomatic disease at a local site before your CAR is ready. Are these the indications? I think more of these thoughts scientifically will unravel in the radiation oncology world, and less of more high-dose radiation therapy. At Tata Medical Center, we choose decisions carefully as a team, and the doses are based on lesions. Most importantly, even before outcomes, is the projected or the planned treatment for the patient, and of course the outcomes, because at the end of the day, it's a patient who comes to us for their lives. With that, I thank you for your kind attention.
Thank you, Dr. Rimpa. Any question for Dr. Rimpa?
You mentioned the role in impending pathological fracture. So I want to ask the question that can it be used in case, because other option, which is to do surgery, is ideal, but much more expensive than radiotherapy. So, has it been used that way?
It's a good working question. But I'll just tell you our policy as a group in this hospital: anything that's a pathological fracture at an eloquent weight-bearing site, be it the spine, be it the lower extremity, we go in for surgery. If it's a lower limb and there is a hairline somewhere, patient in pain, can be managed with immobilization and biologics started for disease control, that's our plan. If it's an upper limb fracture that has a neurovascular bundle at stake, surgery again, sir.
So, internationally, what they do is they do surgery for impending, even
that's what we do as well.
So, but, I know it's a huge expense, as well as it delays the primary treatment, that kind of surgery for a hip replacement or something. So, whereas in India, radiotherapy is so much easier, cheaper. So, if there is any data or any
again, I'll tell you, I'm a radiation oncologist at heart, but anything that may be cheap and easily available may not always be the best in those selected situations. So Dr. Reena will vouch, even if there is an impending, and we know that with biologics, grade 3, grade 4 neutropenias happen with cumulative doses or with later on. So we start the biologics, the patient gets the intervention, comes back, gets physiotherapy, and we come in only when there is refractory pain or there is a soft tissue component which is not behaving well to the combination of novel agents.
For a patient who has solitary plasmacytoma, radiotherapy can be curative. So my question is, when you are treating such case, does your approach or dosing or planning varies if you are treating a skeletal plasmacytoma or a soft tissue plasmacytoma?
So we decided as a group that in this radiation oncology little time that we had for ourselves, and very reasonably so, we would not discuss solitary plasmacytomas as solitary plasmacytomas, that we would discuss radiation for plasmacytomas in the setting of multiple myeloma. However, in order to answer your question, sir, for solitary plasmacytoma, radiation therapy at moderate to higher doses to good volumes based on MR imaging that also gives marrow and soft tissue extensions along with PET. You know, my hemat colleagues will tell you we ask for a lot of imaging just to tailor and be precise with our radiation portals. That's a niche discussion by itself. And I'm sure in one of the later hemat national meetings, you'll have a full session on solitary plasmacytomas.
Thank you.
But the other question on bone versus soft tissue.
Dose.
Yeah, soft tissues do very well with biologics. They often melt away. They are very exquisitely sensitive. And our team, a referral note is often review after 3 to 4 cycles to understand that. If we have a doubt and the patient has a persistent symptom, we do a limited MR of that site to understand. We hardly ever come in with radiation therapy the moment we get a referral.
Yeah, Dr. Rimpa, I have a question. Dr. Rimpa.
Yes.
So, in many patient comes with severe back
Sorry,
pain.
I missed the chairman.
Severe localized back pain at diagnosis. So, what you showed that for pain relief radiation, which usually subsides with therapy, but it takes time. So, do you suggest that it has a role in these cases or only in refractory cases radiation should be used?
Ma'am, if I have to answer a spine question, I am then looking at metastatic epidural cord compressions. So if there is an impending compression and up to
nothing like
no cord compression, ma'am, then excellent analgesia. There is hardly any role of elective radiotherapy. However, it is very important that even if there is no cord compression, one looks very carefully at spinal stability.
So, thank you, Dr. Rimpa. I think we can conclude this session now. There is a panel discussion.
Thank you all the speakers for such an excellent and elaborative talk. Thank you, chairpersons. I would now like to call upon Dr. Joseph John to moderate the panel discussion for adequate pain management and quality of life issues in newly diagnosed multiple myeloma. Sir, if you could please introduce the panelists.
Thank you, Dr. Reena, for inviting us and for having this wonderful gathering at 5:45, 6 p.m. in the evening. So I would like to invite Dr. Arvind Mathur, Dr. Gaurav Prakash, Dr. Atul Sharma, Dr. Naved Tamboli, and Dr. Smita Saldana to the panelist chairs. Yeah. Dr. Arvind has not come, right? Okay. So we have 4 panelists, and of course we have the senior faculty here who can also add on to these discussions. As we continue, this is one. Okay, it is moving. So I thought we will have discussions on 3 levels. One is communication, pain, and quality of life. And so my first question to Dr. Gaurav is, you have a patient with multiple myeloma, newly diagnosed. How would you want to break this news?
So naturally, diagnosis of any malignancy is a life-changing event. But then I'll also say that we work in a setup where the circumstances are anything but ideal. So I have to strike a balance between the time available to a patient and also being considerate to the needs. But I believe in explaining that this is a malignancy. And you are going to receive multiple courses of lines of therapies over a long duration, including a transplant. So usually I would like to open all of these discussions in the first go.
So you would like to give the bird's eye view first, the entirety of it.
Yes.
Okay. Dr. Smita, often we have patients, relatives saying that don't tell the diagnosis to the patient, but just tell us what is. What would be your strategy there in communicating that effectively?
So usually we will, in such situations, specifically if they are elderly, we will probably break them saying that it's a long-standing disease. You have a disease wherein the treatment is a long duration and probably will require multiple cycles of treatment, the first meeting. Subsequently, we would definitely break the news to the patient saying that you are having a blood cancer or some kind of a disease wherein it is not curable and you will require a long duration of treatment.
Atul, you probably have the maximum experience in this area among all of us. What do you think is the correct thing to do when the Western world says that you must break the news completely and the patient is an adult, he has to know all about this disease? What is your approach here?
So basically we have to tailor what we discuss looking to the profile of the patient, number one. That is very, very important. Because previous center where I used to work, more than 60% of the patient won't be able to understand whatever I do say. And they say, "Theek hai," because the moment they come to the cancer center, they do understand they have cancer. Way back about 20 years ago, I couldn't publish, we presented data in ESCO, where the patient was saying, don't tell the family member that I have serious illness. Okay. Family members saying that don't tell the patient that he has a serious illness. And ultimately, both of them knowing that they have a serious, what is the issue. So actually, the patient, when they come to this thing, having seen the patient, there is always a wait time. Whenever you go to a busy government hospital, this thing, patient will be waiting for 1 hour, 2 hours or so. They do discuss with the other patients what do they have, and this is usual, very, very usual. Unlike Western world where they may not be discussing anything with the other patient, whether the physician or the patient themselves. Our patient probably they will be discussing everything and each and everything with not only the patient, other patient family member also. So they have a fair idea what they have. Only thing is that once you break the news, that confirms that they have idea. But you are breaking a news and giving them the confirmation that you have a malignancy, you have a cancer, and that need to be treated. So that is one way of looking at it. But obviously, you can always sometimes sugarcoat your statement saying that you have a disease which is one of the cancer, but this is one of the cancer where the prognosis is good. We have available means, many kind of the therapies are available. We consider particularly for the myeloma, this is just like a chronic disease nowadays. I many times say that this is something similar to diabetes or hypertension which cannot be cured, but probably you keep on living with the disease for many, many years.
Sure, so you reframe it in such a way that it is understandable to the patient, and of course you're not saying there is one size fits for all, it have to be tailored. So Dr. Navedu, in terms of a relapsed myeloma, and you are in a situation where he has used multiple lines of therapy or at least 2 lines of therapy, and it's a difficult situation to convey, would you go ahead and say that the prognosis is very poor and this is the overall survival? This is basically for the students. When they talk, some of them talk in PFS and OS to the patients, and what would be your approach in that situation?
So first of all, what I would do is see what is the financial scenario of the patient. So
can you put the mic closely?
First, what I would do is I would see the financial scenario of the patient. So if he is financially stable and he can afford some line of further treatment, I would counsel in that way. Okay, so this is not the end. You have some line of treatment that is a costlier affair. But if he does not have that much of financial aid or something like that, still I would would refer to him some of palliative of treatment, some low dose of chemotherapy thing, and I would counsel him that see, this is not the end, but still we'll try to give you something, we'll see the response, some positive way will help him. See, once you try to counsel in the negative way, it goes a very bad impression on the patient. He may have some psychological issues, so I counsel in that way.
Sure. So of course what I understand is that you will positively frame it without telling the numbers directly. Okay. Pain is both a positive and a negative phenomenon, and it is double-edged sword. Without pain, life would be like leprosy. We would not know when the hands are getting cut off, and of course it also gives us some sort of a resilience if it is emotional pain, or preventing the negative effects of the physical part of the body. So, in understanding an application of pain management, we need to understand that very carefully, especially in forms of myeloma. And we talked about aspects of when to use radiation therapy, when to use the biological, when to use the bisphosphonates. First question to Dr. Atul. In terms of causes of pain, just to enumerate for the audience, there could be two types of pain we can see in myeloma. It's disease related and treatment related. Can you just enumerate both these to get everybody in the picture?
So basically the disease related one and the most common will be the bone pain because of bone involvement, which is probably in various series from the India and elsewhere have suggested that most of the patient will present with the bone pains and this thing. That is one thing. Bone resorption and so many other things. They also have the neuropathic pain. And sometimes if there is a plasmacytoma sitting or compressing a particular structure or this thing, that also will be giving some kind of the pain. So these are the 2 or 3 common types of the pain which we see in multiple myeloma. And probably they may have to be dealt with in a different way because if the bone pains and so, sorry, what was the second question?
You know, in terms of disease-related pain and treatment-related pain. 2 types of pain we encounter there.
Okay, so the treatment-related pain, basically if you are patient experience, you are saying then probably most of the time this is neuropathic pain, which we see, I think, so with the use of this embolism, basically various proteasome inhibitors and this thing.
Okay, thank you. Dr. Gaurav, in terms of managing acute pain in a patient, say for example a vertebral compression, fracture, gibbous, there is tenderness, newly diagnosed, what would be your, for the residents at least, what would be a 1, 2, 3 strategy in a step-up manner?
Yeah. So in this situation is one of the medical oncological emergency where the first attempt will be to reduce the intramedullary pressure. And the drug to go to is our favorite dexamethasone. High dose pulse dexamethasone should be given. I would also initiate, if our doctor is there, urgent radiotherapy consultation because radiation not only reduces the edema, it in fact it can increase, but it reduces the tumor burden and that leads to instant pain relief. So these are the 2 initial thing I will do. Obviously, there will be addition of opioid or acetaminophen depending on upon the intensity of the pain. NSAID, all of you will agree, we will avoid for the reasons understandable to us.
So, any one of you differ in the use of RT upfront? Would you want to wait for a couple of days before you initiate RT? Or all of you would say on day 1 itself RT has to come in?
Not on day 1. I said I'll initiate a consultation with a radiation therapy.
Now, when would it come in and what is the point at which you'll decide, yes, we must give radiation now?
So you gave a situation where there is a kyphosis, gibbous formation, so I am taking it as an unstable spine. And and that is clearly the reason of pain. Radiotherapy is definitely going to reduce it, but if you are planning a surgical fixation, then radiotherapy might delay or reduce outcome of a surgical fixation. It is a very difficult point. It depends how quickly you can achieve a surgical fixation or stabilization versus if there is no scope of surgical fixation, then definitely...
So no neurological compression, no neurological deficit, there is compression, but there is extreme pain. That's the situation on day 1 to you.
Right. So in that situation, dexamethasone and pain control as well as some immobilization or rest.
Send a consult to radiotherapy. So I must give it to Dr. Rimpi to probably answer that question. What would you do?
Yeah, I was actually squiggling in my seat there to answer this. No, so I just wanted to mention that when we evaluate such patients on imaging, the moment he says kyphosis, I know it's an unstable spine. The moment he says severe pain, it's probably a retropulsed fragment of bone. Radiation is a contraindication. We would activate neurosurgical activities because with a retropulsed fragment into the spinal canal where the anterior spinal artery flow is compromised, radiation also causes edema. So we see a lot of syringomyelia and myelomalacic changes. So retropulsed fragments, kyphotic spine, patient in severe pain, these are indications for surgery.
Absolutely,
and biologics.
there is no disagreement. Thanks for the comment. We said that this... Yeah, so I think Smita will add what I wanted to say.
So I think the thing is in clinical practice, when you send for a neurosurgical consult, many a times it never happens. The neurosurgical intervention never happens. So ultimately we depend on radiotherapy because we start steroids and many a times neurosurgical intervention does not happen. So then we are dependent on radiotherapy.
Okay, yeah.
Yes, ma'am, I think I agree with that. Most often, not most often, in selected situations where there are multiple levels of collapse in a medically unwell patient, where, fixing the spine, the screws will not have adequate grip, those are the indications where we often go in for conservative management unless there is a spinal cord signal change, where we are very cautious with radiation therapy, but we start systemic treatment and stabilizing the spine with physiotherapy devices.
And absolutely, second to that, there is a patient with active myeloma, might have kidney dysfunction, anemia, patient is sick, some infection. For a proper neurosurgical procedure under GA, it may be it is often a very difficult situation, and we really do not have a very clear answer. Surgery, we all know, is a gold standard for unstable spine, right. But in practicality, how many times are we able to achieve it? That is a question to be answered.
Agreement.
So what I gather is that earlier people were aggressive in RT in day 1, day 2, but now we are withdrawing from that, and it is happy to see that a conservative radiation oncologist, usually radiation oncologists will push forth and say we will do the radiation. So, but then you are very clear that you want to watch, wait, and only if it is absolutely essential to come in. One question to you, Dr. MP, is at what point in the treatment scenario would you consider an RT? After having started therapy, pain is persisting, and that is disproportionate to having given the medication. Probably there is a compression and an edema which is there, not amenable to steroid or opioids. Would you then come in and give an RT? You said 3 to 4 cycles earlier. Would you give it in the first cycle?
So that depends, because we know that for any chemo, biologic, novel agent response, there's time to response. And radiation therapy is something which, if I've delivered, I cannot take it back. There's no antidote to radiation therapy. However, if you are putting me in a sad spot that the patient is really not responding and the analgesia is spot on, but there's still pain. If the imaging is recent, I would go on that imaging. If it's an old imaging, I would repeat and then go in with radiation.
Okay. Yeah, why not come here? We have a seat here. Please come, because there's various discussions happening anyway. So,
no, even if you are outside the home ground, we are got it.
Come, please come. So we have Dr. Arvind Mathur who's come in late, and so we are just discussing regarding the pain and the interventions available for a patient with backache and a gibbous compression fracture. What is the best option? I want to know, when would you consider vertebroplasty? Or if at all you consider at all.
I think I'll just like to first give one. I am a physician, primarily, internist. We are practicing general medicine, and we are also working primarily for the caregivers. Okay. So what brought me over here amongst all the specialists who are there is that we are looking for all these problems from the
caregivers
view aspect.
Wonderful.
And the caregivers aspect.
I have a few questions to you as well then.
Yeah.
So among the panelists, anybody wants to talk about involving the neurosurgeon and saying, I want, or a spine surgeon to saying, I want a vertebroplasty on this particular patient?
Sir, if there is a fracture which is going to be an impeding cord compression, at that time I would like ask the neurosurgeon to go for the vertebroplasty if possible in that patient.
Sir, for vertebroplasty, we need IR team, and for a patient who has undergone compression collapse, vertebroplasty will be of limited use. So in a patient with a large lytic cavitating lesion, painful, which will be because of weight bearing, that is where the vertebroplasty will be useful, and definitely. But here the already deformity has taken place, so I believe that vertebroplasty may not help that particular spine, but the other sites are there.
Okay, so we'll move on a bit more. In terms of caregiver's point of view, a patient in newly diagnosed multiple myeloma in pain, doctors are giving the opioids and anti-inflammatory. and dexamethasone. And we are hoping that the pain is getting reduced. And from the caregiver's point of view, what would you want the caregiver to do, and what do you want the doctors to know how to deal with the caregiver?
I think that's very important, really. What we feel that the caregiver has an important role in managing pain in newly diagnosed multiple myeloma, because he's the one who is going to observe the gravity of the situation, would also try to understand the interventions which are being done, and help the patient to come navigate those particular situations. So I think as a caregiver, we need to educate them about what they have to observe for the pain or all the problems which are occurring with the myeloma, and they would then ensure the compliance of the therapy also, and reporting to the healthcare professional also about this particular part. So I feel caregivers have an important role both in identifying the problem, helping the management of that particular issue, and trying to avert these emergencies also.
So from the physician's point of view, we need to identify who are going to be the caregivers for the particular patient, involve them in the discussions as well.
Yeah, definitely, because we are all talking of patient-centric management these days. In patient-centric management, we have to identify a primary caregiver who would be responsible for most of the care and the decisions for that particular patient. So it is always better to involve them in the discussions for the management of that patient. That is what is
sure. So Dr. Navendu, in terms, we've just had a lot of discussion regarding zoledronic acid and denosumab. Would you find either of them better or worse in pain control?
So it's not like better or worse, but both are can be used even in pain management also, because what the most common cause is your osteolytic lesions that are going to cause all this pain. So zoledronic acid and denosumab both help in healing that lesion.
So you would weigh both at the same?
Yes.
Depending upon the renal failure, hypercalcemia, you may decide upon denosumab coming. Any other suggestions on this?
Some evidence and thought that denosumab probably can be faster acting for pain relief. So, I mean, this going by the cost, it can be a very soft point to choose it. But in some cases where severe pain and somebody can afford, so maybe you can start with denosumab. And Dr. Pankaj, I think, mentioned that you first dose, it will look after hypercalcemia, rapid reduction of pain earlier, and then you switch over to after second month or so.
Okay. Dr. Atul, regarding the treatment-related pain, paresthesias and neuropathic pain is one of the major issues. And in those situations, we all go to pregabalin or gabapentin, maybe add on amitriptyline. Beyond that, anything else you want to say, or you want to say how to schedule the medications in such a way that we get around-the-clock pain control?
So basically, being conservative, usually we start with the amitriptyline. Okay. And then we go for the gabapentin and
10
that
mg
thing.
once a day?
Yeah, at bedtime. Yeah. And nowadays, I have personally found duloxetine is probably little more useful. So I've seen it does give a lot of sedation. Duloxetine, yeah.
Duloxetine.
Yeah.
Duloxetine.
So it does give a lot of sedation though, but I've seen that particularly used in solid cancer, oxaliplatin-induced neuropathy, and that personally I've found it very useful. We start with the low dose. If the tolerance is there, then probably you keep on building up the dose.
So the gabapentins are not coming into the
So they do come. They do come because the gabapentin and the pregabalin, they used to be available at the IMC pharmacy, and this thing, it was easier to use. Amitriptyline is very cheap, and duloxetine, and they are probably a little more expensive in this thing. So that's what.
Any other suggestions on pain management, neuropathic pain management? Because this can be one of those difficult ones.
Gabapentin is age old and quite effective. The only issue I see that is a TDS dosing. So it's always for a patient who's on multiple types of oral pill burden is there. So triptomer, duloxetine, pregabalin, all of these can be given once in a day, bedtime, and the sedation can be tided over the sleep cycle.
Would you give all the three in one patient if required?
Difficult call.
Dr. Smitha?
I think when the pain is not at all managed, we have given all the three. But initially we'll start with the amitriptyline, add pregabalin, and then last I go to duloxetine.
Okay, Dr. Mathur, in this situation, what is your comment?
I think we will definitely first start with tricyclic 1, and then after SNRI or the gabapentin could be used. Combining 2 antidepressants would be difficult. So we would have 1 antidepressant and
one pregabalin.
Gabapentin or pregabalin.
Any drug interactions we need to be watch out for when we give amitriptyline, cardiac amyloidosis, you don't want QTC prolongation, etc. What are the take homes you tell the residents when you start amitriptyline, what should you not do?
I think the amitriptyline has an important issue is the anticholinergic side effects which would occur. Particularly my older patients, I'll be watchful for the problems related with prostatism also. Okay. And of course, cardiac side effects have to be observed, but the doses which are being used for the pain relief, they are usually minimal doses, so cardiac problems usually won't occur in them, but we have to be watchful for cardiac side effects and this anticholinergic.
So would the strategy change in an amyloidosis patient? Would there be any modification in the pain management when it comes to an amyloid causing peripheral neuropathy? Or same?
I think it would.
Cardiac amyloid, would you want to avoid amitriptylines?
Of course, in case if in amyloid situation, if the cardiac involvement is there, then it is better to avoid these drugs because they do have cardiac conduction defects, etc. would occur.
Sure. So we discussed some of these things already in the discussions, and in terms of involving other specialities, of course, how often would you call a physical medicine rehabilitation or a cross consultation with orthopedics in terms of these? When do you call a physical medicine rehabilitation person? Dr. Navendu, PMR, if it is available.
So if it is available,
can you put the mic closer?
So if it is available, yes, surely I will get a consult from the physiotherapist, but not in the initial part. First, I would like to stabilize the patient,
stabilize and then
see
go
if
ahead
there is any fracture, and then only probably will move into it.
Sure. So when it comes to quality of life, I mean, equally important for the doctor's quality of life also, but when you look at a human being's quality of life, look at his physical functions, physical body, I mean physical nature, his functionality of things, intellect and psychology, societal interactions. And among this, it is, there are various quality of life aspects, measures available. On a practical note, Dr. Atul, do you ever, or what is your OPD strategy of looking at quality of life? Is it practical, not practical? How do you go about it?
So quality of life is very important, but many times I think I do agree that we don't address in the clinic. We do discuss in many of the meetings and this thing, but when we come to one-to-one patient and this thing, I don't think that most of us will be doing. At least I haven't done it for many times. I may have been doing it sometimes, but I don't say that this thing. Usually first line definitely, but if becomes the treatment is subsequent line, then we always discuss that at this point in time, the quality of life is very, very important, where the response is, and there are other issues, financial issues, economical issues, the social issues, that patient, whether somebody is there, because these are the patients who are many times elderly. They need to be transported to the hospital in a not an easy ways. They are many times may not be ambulatory in this thing, from taking one clinic to different clinic consultation, this thing. But I do understand and stress that this is very, very important. We should recognize and we should be looking into this thing, the best way that they're putting ourselves into similar situation. So that is the way when you really get an insight that what should we will be doing or that we should be doing. So that is one thing.
Dr. Mathur, from the caregiver's point of view, what are the
this particular issue is important for the patient and the caregiver, definitely. And as has been mentioned by Professor Atul also, that these tools which are available right now with us, I don't think they are practical because they have been prepared in the West. They do not look at the life values which we inherit or which we have. So a good clinician, by his interaction, would also know about how his patient is doing and what is his quality of life.
Pain and quality of life, all of us agree that communication has to be tailored made for each patient depending upon the social scenario. Pain management, we discussed about the algorithms here, and the quality of life importance, at least address those physical, mental, emotional, societal needs which the patient needs to be functional in the society. Thank you very much, and thank you panelists for answering the questions, and thank you Rimpi for coming over.
Thank you, speakers, for all the knowledge shared. I'm sure it will help us in better patient management. Moving on to the last session for today. The next session will present the Indian data for better insights. I kindly request the chairpersons to come on the dais. Dr. Ritu Jain, Consultant Medical Oncologist, Jaslok Hospital, Mumbai, and Dr. Prantar Chakrabarti, Senior Hematologist, Department of Healthcare Innovation, Zoho Corporation, Tamil Nadu. I request them to kindly. Oh, okay. I would request Dr. Jeevan sir to please come on the dais. I would request them to kindly introduce our speakers.
Thank you, Dr. Nupar. So, first speaker will be Dr. Ritu Gupta. She is a professor and office in charge in laboratory oncology at AIMS, New Delhi.
Good evening, and thanks for staying back, those who are all here. So I would like to express my gratitude to Professor Deepak Mishra and Professor Reena Nair for inviting me to this meeting. In the next 15 minutes, I'll talk about the data and the leads that my research group has developed on AI, using AI in multiple myeloma. 15 minutes is a short time to take you through all the work, but I'll just give you an overview. And for those who would like to reproduce this work, the codes are given on the slides, and this work is published, so you can refer to the papers, and I have given the references here. So this talk will be in 3 parts. In the first part, I'll talk about the AI-enabled myeloma diagnostic tool that we have prepared on microscopic images. In the second part, I'll discuss how we have deciphered oncogenesis and reduced a clinically relevant NGS panel for testing of myeloma patients. And in the third part, I'll show you the AI-enabled staging systems that we have developed for Indian patients with multiple myeloma. So to build an automated cancer diagnostic tool using microscopic images, what we require is data from large number of annotated subjects. The data has to be captured and annotated by trained hematopathologists in this case. The challenges that everybody encounters in microscopic images is normalization, stain normalization, which one of the previous speakers also showed today during the day. The another aspect which is specific to the hematology AI is the clustering of cells, and I'll talk about it a little later. So that clustering of cells has to be handled by segmentation of the cells, and following which you have to build a classifier which can automatically detect between the normal and the malignant class. And for it to be implemented in the clinic, you need to make a GUI-enabled automated tool. So this is the description of the data set. So essentially the plasma cells from the patients not suffering from PCPD and those suffering from multiple myeloma were collected, and the data was annotated. And this is the first challenge that I'm talking about, the stain color variation. On the left side, you have the reference image, and these are the 2 images that I'm showing you. You can see that there is an appreciable difference in the stain color. And after using our pipeline, these images are matching, the color is matching so much with the reference. This is just a crude way to show you, although practically we do a lot of technical calculations to show that these are the same. So this is the overview of the pipeline that was used, and the link for the paper is also here, and the codes are available on the GitHub. The second challenge I said was clustering. In myeloma particularly, there is a overlap of the cytoplasm, overlap of the nucleus to nucleus. Then sometimes you're not able to segment out the cells because the cytoplasm literally is blending with the background. So these are some of the challenges, and so if the challenges are so many in segmentation and clustering, then the pipelines would also have to be many and tried out well. So the first pipeline that we prepared was using the watershed and the circular hook transform, and what we found was that the positive predictive value was somewhere between 50 to 70%. We were not very happy with it. And later on, we use a CNN-based pipeline using the encoder-decoder, which was based on CNN. And here we were reaching the positive predictive value of more than 90%. So then we got encouraged, and we used this because this was a humongous data set and it is not available internationally anywhere else. So we threw the challenge in the IEEE conference, and that happened in 2021 in France, where 52 teams from 12 countries participated, and all the top 5 teams used the deep learning based approach, which is another manifestation or another form of AI. So these results have been published, and you can refer to the paper for the detailed result. So all the 5 pipelines worked very well with the myeloma cells. So the next challenge that we had was to achieve class identification, that is segregating and identifying the normal as normal and the malignant as malignant. So for this, the challenge is, because you know that the plasma cells are similar in malignant as well as the normal individuals, and within the myeloma patients also there is a marked variability in the appearance of the plasma cells from different cases. And because the third challenge is, because whatever number of cells you acquire, you will always be able to get more cells from a malignant patient, and you will always have less number of normal plasma cells in your data set. So there is always a class imbalance that introduces noise in one class. So we use this huge data set from 72 subjects, and we use 3 algorithms: the projection loss, the dual branch architecture, and the coupling classifier to achieve our goal of classification. And so this is the prototype that we made, and on the right side you can see that we have made a GUI interfaced automated tool where it can do the normalization and segmentation and classification at the push of a button. So to validate this, what we did was we took 24 myeloma patients and collected images compared with the next generation flow cytometry, and this is the comparison. So in the red highlighted, you can see that there is a coefficient of variation between the 2 values is more than 10%. So obviously it is because of the number of PCs analyzed by the NGF are much higher than you can collect using manual microscopic methods. So now the effort is on using WSI on the images so that we can acquire per patient more data, number of plasma cells, and then we can use this tool for MRD in multiple myeloma. So this is the work in progress. So this is a summary. We've achieved stain normalization for cell segmentation. We have now more than 5 pipelines. And an international group also did a segmentation challenge, and which is published in Nature Methods. We have 2 tools for classification of cells, and an automated prototype is ready. And next year, I'm hoping that I'll give you the good news that it's active and working for MRD. So the second part is deciphering the oncogenesis. We know that the only differentiation between MGUS smoldering myeloma and myeloma is the percentage of the plasma cells, or in total the tumor load. And people by large have shown that the molecular aberrations that are present at the MM stage are already present at the MGUS stage. Another challenge is that sequential data of genomic data of MGUS to MM patients is smoldering and MM patient is not available for us to decipher what are the key molecular changes between this. So we thought, let's see if we can use AI to address this question. So what we did was, after getting the A24 significantly altered genes using the regular pipelines, we used 28 genomic features. Since this is AI, it can handle multiple parameters of a single gene. And then we used the graph convolution network, and we identified the parameters which were significantly different between these 2 stages. We did a pathway enrichment analysis and also identified the pathways which become more significant as the disease advances from MGUS to myeloma, and those which become irrelevant as the disease advances from MGUS to myeloma. Both of them are important. So as you can see, these are the pathways which are different between the two disease states. But I would like to highlight that the osteoclast differentiation pathway, which significantly was distorted in myeloma, was not distorted so much in MGUS state. So that tells us why you have lytic lesions in MM and not MGUS. And similarly, now you can use this information to deduce the pharmacotherapy which will be relevant if we were to try and stop the progression of MGUS or SMM to multiple myeloma. So this is the take home from, we can use the therapeutic potential of this model. The second question we asked was, now can we use AI to develop genomic assay for clinical testing? Most of us who are working in this field do realize that every third year or fourth year another panel comes up and another set of genes comes up, that this is significant now, that is significant. So let's address this challenge, and for once and all. What we did different here from the previous model was, here we also integrated the, what we identified the markers which are heralding the progression of MGUS to multiple myeloma. Now here we were interested in identifying the markers which portend a poor prognosis, the progression and reduced overall survival in myeloma patients. So we integrated the survival data for these patients into this model. And additionally, we also identified certain genes which are not just the reported oncogenes and all, because here we used a different, normally people use cytoscape and similar tools available, bioinformatic tools, to decipher the, the nodal genes and the gene-gene interactions. So here we use the AI-based Leiden algorithm and the CAT centrality scores. So this threw up a lot of other genes. In the magenta, you can see that those genes by the size, they hold a lot of significance in this community, in this pathway. But they are not reported as an oncogene or the tumor suppressor gene. So that is why we have been losing information, in our routine bioinformatic analysis. In every third year or fourth year, you're coming up with one of these genes get classified as a TSG and an oncogene, and now you have to check for that. So this AI-based analysis, this is unsupervised and gives you much more, and it is expected to be more robust. So this is the survival analysis validation, which we not only use the univariate analysis, but we also use the FMAD survival analysis to check for the robustness of these genes. And here we reduced the 282 gene panel, but then we added 13 genes which were already known to be significant in myeloma and used in current classification to make a 295 gene panel. So in summary, we have identified, we have explored the process of oncogenesis. We have given a model which can be therapeutically exploited, and we have found a clinically relevant, prognostically relevant target panel for myeloma patients. Now the last part is I have 2 more minutes. So AI-enabled risk stratification and staging in multiple myeloma. So what are the challenges, current challenges in staging that we face? Not all our patients, we are able to do the RISS, right, because of the lack of the genomic aberrations. The lack could be because of the lack of facilities at the peripheral centers, or because we are not able to isolate enough number of plasma cells. The bone marrow is diluted, you don't have enough number of plasma cells. Or what do you do when those patients are referred to your centers? Can we not stage them? Do we really have to go back to the ancient staging of ISS only? So is there so that was one question. And second question is, we do realize that different ethnicity populations have different parameters. For example, anemia is more common in our population than the Western population. So do different parameters contribute differently in different populations? So can we evaluate whether ethnicity is making an impact on the treatment outcomes? So for example, for the same 80% of our patients are in stage 3 and stage 2, and 20% in stage 1. And in the West, it is different. Is it just because our patients are coming late? Or is there something else? And the same patients, some of the survival data for the same stages is not same in West and in India. It's not just because we are third world countries, there are other reasons at play. So when we looked at it, so first question was, where can we make a robust staging algorithm independent of genomic biomarkers, because this is the need of the day. So we took two data sets. The Indian data sets was from the IMC. So we had a total of, after excluding everything, where the data was not available or follow-up is not there, we had more than 1,000 patients and 900 from the MMRF data set. So this is the overview of the staging system. We use 6 parameters: age, albumin, beta-2m, calcium, eGFR, and hemoglobin. LDH did not come significant, so we omitted that. We found the thresholds using CAP. And then we made the adjacency matrices, and here we use the Birch clustering to cluster them into prognostically relevant groups. Mind you, we already had the information on survival analysis that was used in this classification, and used, then we assigned the risk. So here, this is not simple like ISS, you have plus minus this cutoff, that cutoff. It's a hierarchical rule-based tree structure, and this is more robust. And here I would like to just take 1 minute to emphasize that we did have a talk where it was said that the PFS is what now we are going to measure in the clinical trials, and not the OS, because you have more recent treatments coming in, and it's best to evaluate on PFS. So if you look at the ISS and revised ISS, they are more strong in terms of predicting overall survival and not the progression-free survival, where the curves I show you in the Indian and the MRF patients are overlapping, whereas in the MRS, which we have developed, the curves are separating nicely, the p-value is more significant. So it's more robust than the RISS, which is using the parameters. So this is the link on our website, on the AIMS website. You can use this calculator to look at the risk prediction for your own patients and study your population. So now the second part, we looked at the ethnicity, and here we looked at that the parameters except albumin were significantly different in the Indian and the Western cohorts. And we deduced the new threshold for both the populations. And you realize that the beta-2m, important to note here is, for our population, the cutoff for the beta-2m is less. So essentially here we used GMM clustering, which is Gaussian mixture model, instead of Birch, because Birch does not take care of the outliers, but in real life outliers do happen. So here we use the GMM clustering, and this is a more robust because it took into consideration two levels of graphing, the adjacency graph and the consensus graph, and we again made a decision tree classifier, and these are the results. So you can see that CRSS performs very well on Indian and the MMRF patients. So when you use the algorithm which is specific to a population, the results are much better. So the second part is, do all parameters contribute equally in both ethnicity? No, they were different. HRCA was more important in predicting CRSS3 in our population, whereas beta-2m and lower values of hemoglobin in the Western population. So this is the calculator, which is again available on the AIMS website. For those who wish to use it, can use it. So to summarize, we have built an AI-enabled myeloma diagnostic tool on microscopic imaging, and we are just validating it for determining MRD in myeloma patients. We have shown you a model of which can decipher oncogenesis, and we have built a clinically relevant myeloma panel, and the validation is going on. And we have shown you the AI-enabled risk stratification for staging of multiple myeloma. But we know that as therapy involves, all these prognostic models need to be changed. So I really think that generative AI has a potential because in this field, because it can evolve over time and will be more relevant in times to come. So I will end by acknowledging my colleagues here, Professor Lalit Kumar, Dr. Atul Sharma, and Dr. Ajay Gogia from the clinical side, Dr. Jaina, who did a lot of bioinformatic work along with Dr. Gurvinder. Dr. Lata produced the data set for the genomic data, and Dr. Anuba and her team, Shiv, Vivek, and Akansha did the AI work. So Shiv did mostly the imaging work, which is published in Medical Image Analysis. Vivek did a lot of genomic work. Now he's at University of Columbia. And Akansha worked on the risk staging models, and she's currently at UCL, London. So I'll be happy to take any questions.
Yeah. Thank you, Professor Ritu. I think you have already shown the proof of concept, but because of time constraints, you can discuss with her one-to-one. And she'll tell you how easy or difficult it is to talk to engineers. Next would be Dr. Uday, who does not need any introduction. He'll be speaking on how he has screened monoclonal gammopathies. So over to you then.
Thanks for the introduction, and I will not take much time. Many of you would have already heard this presentation during the Hematocon. I'll quickly go through, but definitely there are some upon to this. So why this study? So as we all understand, we need to pick up myeloma at an early stage. So we have got MGUS, moldering and active myeloma. The earlier we pick up, we can prevent. So it's like a fire. So before the things are burnt or the target organ damage, it's always better to prevent rather than treating a complication or a target organ damage. MGUS does have a high risk of evolving into multiple disorders depending upon what type of M protein are we looking at. And if we look at the Venn diagram to show what all MGUS involves into or evolves into, so this is what it is. So the bigger blue circle is what we are looking at, and the incidences, the numbers which are written in the bottom, these numbers are not available from our country. So our aim is to generate these numbers for our country about what is the incidence of MGUS in our population. For the West, we have 3 primary studies which talk about this. The Olmsted County data by Dr. Bob Kyle, which is now being taken over by Angela Dispenziari. Thereafter, iStop-MM, and which is an Iceland study wherein the complete country was screened for the MGUS, and they have the largest data on MGUS across the world. And the last one by Irene Gabriel, the PROMISE study, and wherein she has in the recent ASH presented a concept wherein she says 40% of the population have got MGUS. And they have termed a new term known as MGIP. This is good for the myeloma community. So which is monoclonal gammopathy of indeterminate prevalence or significance something. So like CHIP that we have, so clonal hematopoiesis, ISCHIP. So they have termed a term known as MGIP, and they have shown the data that anybody beyond 50 years of age, so if in the hall, half of you already are having MGUS, is what she has shown. So back to this, so M-spike. So our concept is how to detect this. So we have done this study of screening intervention for myeloma and prevention of lifestyle diseases in collaboration with IMAGE, and our aim was to do a door-to-door screening, and for this we went upon to 2 particular locations, and by approximately spending around 1992,096 man hours, we have tried to, over 97 days, with 56 medical teams, we did a door-to-door survey, because the current data across the country, the only data that we have is from AIMS. Ritu ma'am and Lalit sir has a data of hospital-based information about what is the prevalence of it. But the ideal way to pick it up is to do a door-to-door prevalence and to look at what is the prevalence of MGUS. So we took 8 non-tribal villages and 58 tribal villages, and going door to door, we tried to look at what all they have. Yes, obviously, if I say that I want to look at myeloma, nobody helps me out. So I had to do their anemia screening, their diabetes screening, thyroid screening, and then I also used to say, "Ki main tumhara myeloma bhi check kar lunga," and that's how we could convince people. We requested 91,856 people by requesting them ki sample de do, and out of 91,000, only 10,000 agreed to, and there were areas where there were no Google Maps and no things to work upon, and we had to start from the house numbering to going and saying ki bhai hum kis ghar pe gaye the, kya gaye the, to trace them back, and if at all if somebody comes to be watched, so we gave house numbers to all these locations and these things, route maps created in the night, and thereafter the teams in the morning, thanks to my department and the college which could spare so many people, and we went ahead and did this in remotest of the locations to find out what it is. So you would find guys going on bikes and going in the night in the ganne ke khet for collecting samples and for doing the sampling. So this is how we went ahead and did it. Yes, there were a lot of problems. Pre-analytical errors had to be looked into and various other things. So, but for every sample that we collected, we did CBC, RFT, LFT, total proteins, beta-2 microglobulins, because Dr. Shaji is not here. But the one important aspect across the world which we are looking at is, are the beta-2 microglobulin cutoffs? Because that remains to be one of the important prognostic factor, despite of having R2 ISS on today's date of albumin and beta-2 microglobulin. So what is the exact cutoff where we can say that that is more? So we are bringing out nomograms for that, for beta-2 microglobulin, and finally protein electrophoresis. These are my students who tried to help me out. Yeah, and one second. Yeah. So this was 91,856, out of which 9,283 agreed to give samples. So we were also suggested that for a particular population, take across age, because we really don't know when does MGUS start. So this was based on Dr. Nikhil Munshi's advice to collect samples from birth upwards. So for 8,000 people, we took all ages, of which 45 years and above are 2,691. And from the non-tribal population, we had 756. Of this, we found approximately 220 people who had suspected M-band. They were all subjected to SIFE, and 217 people. And on SIFE, we found around 62 patients who had MGUS. Now, all these 62 patients were subjected to bone marrows and PET scans to find out whether they had overt myelomas or not. So that was the costliest part of the study and the most difficult one, to convince the people to get a bone marrow, when otherwise he was a healthy farmer staying at house and saying, "Ki sir, aap mera kyun ka kya sample le rahe ho?" To the point wherein we had to convince him, "Ki please ek bone marrow kara lo." But we were successful. We went in uniforms without weapon and told them, "Ki aapko sample dena hai." So as sir said, needle lagega, so we followed the same concept, I being his junior. So humne bola needle to lagna hi lagna hai. So finally for 62 people, we went ahead and did the thing. And finally, coming to the numbers, so if you take across age groups, 0.66% is the prevalence of MGUS. If we take above 45 years of age, so 0.66% for this audience doesn't make any sense. Above 45 years of age, 1.6%, and above 55 years of age, 1.79% are the numbers from our country. And when we compare this, and these are the other details, what type of MGUS and other things. So obviously IgG were the commonest, and the lambda was the commonest. And comparing tribal versus non-tribal, there was no difference. And when we did some additional analysis of correlation with AG ratios, because there was a concept which we were only trying to propagate, if we can take albumin globulin ratio as a screening marker, and all those who had AG reversal, only they to be subjected for SPEPs in routine hospital screening, that did not work. It just doesn't work. So if you could see, there's a flat line there. So most of the MGUS do not have AG reversal, and which makes sense. And these are the nomograms that we found out, which is the work in progress. Now, our data when compared to the other data, so China says it's 1.11%, Japan says 2.4%, and there is a study from Thailand, 2.3%, US 3%, and whereas Europe it is 5%. So this is how we compare from other countries. When we say Europe, it is Icelandic study or the iStop-MN. These are various other publications about different percentages. Now coming further, thanks to the president of IMAGE and the executive committee, we have adopted these people and we have said anything happening, because this is a IMAGE 002 study which I am proposing or which I am presenting. So they were adopted, and any treatment required at any point of time, they will be referred to one of the IMAGE facilities for management, though none of them are on any treatment. Now coming to the way forward, this is something which is interesting. So last year post-ASH, we could actually get few of our protocols which we have been working for last 4 years validated at Mayo Clinic. So first thing first, the good news is we are coming up with a mass spectrometry, not the mass fix, not the clonotropic thing, but by using Orbitrap and by using microbiology time of flight device, wherein we have checked our results. We have checked results of 1,000 people at Mayo Clinic, and our results and their results are exactly matching. And with this, we are probably going to get down the cost of M protein evaluation to less than 60 rupees or $1, first thing. So the proof of concept has been accepted. We have applied for patent. I cannot show it till the time the temporary patent number doesn't come in. Number 2, post the protein, PTP is the second concept we have come up with, wherein the individual can actually just post it on a dried blood spot sort of thing. And that also we have validated exactly on what paper and how paper, cost effective one. If that comes through and the proof of concept is there, the cost of testing for the individual without coming to a hospital should come to 1 rupee. So these are the 2 patents we have applied, and by the end of this year, we are looking forward that if these 2 techniques come forward, we have now collaborated with IIT Mumbai and with NCCS Pune to commercialize this from the proof of concept bench side to bedside. If that comes through, so that's one thing which AFMS could be contributing to the society in getting low cost technologies. Second, we have also patented this year, applied for patent for using viscometer, handheld viscometer, which was prepared by me and my students from Scientific Society undergraduates. Just by the way we make our slides, so we have calibrated that, and all component of it when standardized, the speed with which the slide is made and the length of the tongue of the slide on a PBS slide can actually determine how much is the M protein. So we have done proof of concept studies for that. We have tested in around 500 people. It's a surrogate. It's not exactly M protein, but it could be a screening technique for such studies wherein we don't have to spend money and just by putting a spot and by looking into it. Again, this is a study along with IIT Mumbai. One was with chemical engineering branch and another was with Professor Rohit Srivastav. So we have applied for a combined patent for that also. If that comes through by the next year image meeting that we are going to have in Kochi, so we would probably be having some low cost technologies coming up for screening M protein. So with that, I stop here. Now, the study that we are doing, the biggest problem or the challenge was people said this is all Maharashtra-based data. You require other data. So, within Maharashtra, we have taken 2 other districts. So, Wardha, Datta Meghe, Dr. Karan Sood, who is a DM oncology, finally a student, 5,000 samples. The study is already started. Second is Yavatmal district. So, from there, 5,000 more samples. From Bhilai, we have coordinated, we have a MOU signed. We are going to evaluate 60,000 people at Bhilai in the next 3 months. And in Arunachal, next to Nahargaon, we are going to take 5,000. The areas have been identified and we have got written permissions for the armed forces from these areas. And lastly, just now I spoke to my senior Manu Dogra sir, and from Kargil, Leh Ladakh district, we are planning to take another few samples. We propose 5,000, but whatever we get, we are going to take that. And we are going to then have north, south, east, west. We have not touched Tamil Nadu or down south because Nikita is already working there. So we would merge our data with your data to understand how much is the prevalence. So we should not replicate or reinvent wheel within a country. So whatever your data is there, we can merge our with yours. So to get the exact figures across country, what is the MGUS prevalence in our country. But all said and done, at the end of it, the take-home message is doing MGUS screening as part of executive checkups or as part of health screenings or as a routine screening is not worth it, not cost effective, and we should not be subjecting people to that. And the amount of the mental turbulence or the psychological fear that we add to the individual when we tell them ki shayad aapko cancer hai, the agony to the family and to the individual is huge. So irrespective of the money component of it, because I have been facing these people, these 62 people, and their questions, even if they get a cough and cold, they get, sir, mera cancer to nahi badh gaya hai. So I think it's not worth it. We should not be subjecting. As part of research protocol is different, but in a routine, we should not be subjecting. So that's where I am. Thank you.
Thank you, Dr. Uday. So for planning such a difficult study and conducting this is very difficult. So we congratulate to you. So we have 5 minutes for any questions.
Yeah, please, sir. Sir, anyone, sir.
No, I just, the last patent that you're talking about. So won't that, the length...
To present it because they said till the time we don't get it. So the fact is we have, when I said we have standardized all residual components. Whenever we are talking of smear, so there are multiple factors to it, starting from the pressure application, to the slide, the width of the slide, the glass slide, the margin, the speed with which it is being made, the hemoglobin levels, the TLC, the platelets, the plasma volume, multiple other factors. So there are ways and means of doing it. So it's not one day work. So last 4 years, we have been working first with Newtonian fluids. Then we made dilutions of Newtonian fluids. Then we worked on CBCs, then we worked on different hemograms with different anemia levels, hemoglobin levels. So all put together, now we have created a sort of calculation based on HB. If you enter HB itna hai, TLC itna hai, platelet itna hai, cholesterol itna hai, because lipids also make a difference. So cholesterol itna hai, urea creatinine itna hai, and albumin itna hai. Then if we enter all these things, then with that particular thing, we can approximately tell what it is. And then we have checked the counter check the results with rheometer also. So the rheometer standard comes at around 50 lakhs to 1 crore. So we checked those with the viscosity with that, compared, ensured that, and brought it out. So it's a work which has been done for last 4-5 years to say that it closely mimics. But I myself gave a small asterisk at the corner and say it's not the direct measurement. Its utility might be for a known patient with M protein and to monitor the same patient over a period of time. So I know uska pehle kitna tha, baad mein kitna tha, number one. Number two, for screening, when I'm doing mass screening rather than doing everybody SPP, this is one test where I can use the same slate thereafter for PBS. So all said and done, it has its own caveats, but obviously the cost of that viscosity meter when we are going to do it for testing is 10 paisa. Except for washing that slide, no other cost involved in it. So, and the lancet cost for taking the blood drop. So,
there are so many other parameters that cost of those will be there?
So, sir, generally, when we are going to utilize such instruments, it's that, for example, an individual has given his sample in the lab for rest all tests, simultaneously this can be done. So, in isolation, no. So, there are caveats, there are aspects to it. So, it's not that simple as well. Yeah. Sir, Deepak, sir.
The very ambitious study, all the very best for that.
Thank you, sir.
But the thing is that in India, infection is so common.
Sir.
Polyclonal gamma globulinemia will interfere with your spreading of the smear.
Yes, sir.
So whether you are detecting M-band or you are detecting hyper gamma globulinemia will be a question.
Yes, sir.
So you cannot label based on this.
Definitely, sir.
That it is.
Yes, sir.
M-band.
So, sir, that's what. So, that part of it, so it has got different connotation, utility, uses in specific conditions. So, it's a different thing, but at the same time, it's something which we can use it without spending any money. So, we have all those things kept in mind, sir. But yes, what you said is a major confounding, and what you said totally makes sense. So, it has got its own way of interpreting and others. So, that's what it is. Yes, sir, you wanted to also.
Already addressed this question.
Okay.
Thank you, Dr. Uday.
Thank you, sir.
So just a little announcement. Tomorrow morning at 8 a.m. we have a conversation with the myeloma experts. We have restricted entries. So those who are interested can kindly register outside at the registration desk. Okay, moving on.
Thank you. Now we go into another technology which was partially described by Uday. And Dr. Nikita Mehra from Adair Cancer Institute, Chennai, will be presenting on MALDI-TOF mass spectrometry for M protein analysis from bench to bedside. Over to you, Nikita.
Thank you, sir. At the outset, I'd like to thank the... Sorry. So I will be talking about our journey with the use of MALDI-TOF mass spectrometry for the first slide, please. This is the last slide. I promise to finish very quickly. So, so this is bench to bedside research that I will very, very quickly go over the journey. I'm cognizant of the time. I will finish this in 10 minutes. So essentially, I come from the Center Cancer Institute, WIA, and this is a picture of Dr. V. Shanta, who passed away in 2021, the face of the organization. And this was a study, the MCP 841, the ALL protocol that was devised. It was a multi-center study within the country and with some folks outside. And this was with Professor Ian McGrath from NCI Bethesda. He then created the INCTR in Brussels, which was an NGO. And this was a study to bring down the cost of treatment for ALL. And around this time, I started discussing with Dr. V. Shanta about my interest in myeloma research. I returned in 2018 from the first Indian Myeloma Congress at Army RNR Hospital. And this was my first meeting with Dr. Vincent Rajkumar. When he gave a talk on MGUS, he spoke about the 20-year update of the MGUS epidemiology study from the Olmsted County at Minnesota. And at the end of this talk, I did speak with Sir, and I said I expressed interest in running the MGUS epidemiology study. Cut to 2019, I was at Mayo Clinic for just a week in Minnesota, and it was really nice looking at how MALDI-TOF was used in the clinic. I could not go and visit the facility, and a lot of work has come out from, of course, Professor David Murray from Mayo Clinic has pioneered work in MALDI-TOF mass spectrometry, and a lot of studies started coming out around this time. The first study came out in clinical chemistry in 2016. So to talk about my work very briefly, for the work we did file a patent in March 2020, and this was with the use of acetonitrile precipitation. Very briefly, why did we even want to do this test at the institute? I do say this several times. Of course, there are unmet needs that every country has, region has, but I think there are also unmet needs that can be very, they're institution specific. And our institute is a standalone cancer center. Patients come with a diagnosis of cancer unless otherwise proven. And if the patient has a bone tumor, so multiple bone lesions, the patient is primarily evaluated by the surgeons. If the patient comes with a hematolymphoid malignancy, then they're first referred to the medical oncology or the hematology oncology team. And then evaluation is sort of is worked out accordingly. Of course, there's great crosstalk between all the departments, but this was essentially to try and see if we could do a test very quickly and give the diagnosis, tell that yes, there is an M protein. But what was the issue with that? Serum protein electrophoresis, we do know about 20%, 80% of the patients with multiple myeloma will be positive for M protein by SPEP, but 20% will not get identified. IFE and SFLC was very expensive, and I'm very fortunate to have been in Ritu Gupta madam's lab, Lalit Kumar sir's department, to understand M protein and everything that was being done for myeloma diagnostics. Now, at this point, we did not have IFE and SFLC in-house. We were sending it outside. So it was, of course, very expensive. And as we know, patients do not have access to, you do not have schemes for these diagnostic tests. And of course, we have a lot of patients who say, I refuse to have another marrow test. I only want blood assessment. So we were trying to see if we could do something in that area. And this equipment was very kindly given by the government of India through a DST grant to Dr. T. Rajkumar, who was the head of molecular oncology. And I asked if we could use this equipment to try and do the work. So this was a Bruker MALDI-TOF mass spectrometer. And as Professor Yanamandra spoke about, the tabletop, that is the other MALDI-TOF platforms, you do have tabletop devices also. They're all available in several microbiology labs. This is a slightly better version, and it's something that cannot be used in all the labs. They're used in research facilities. But again, the Mayo Clinic study has very nicely shown everything on the tabletop MALDI-TOF device by Bruker. So of course, as we know, the sensitivity of M protein by SPEP is about 80%, by MALDI-TOF it's about 92%. This is the normal Gaussian distribution. So what you normally see on the x-axis, you're looking at the mass. On the y, you're looking at the intensity. And you see a Gaussian distribution. So you see lambda followed by kappa. You're not seeing one clear, neat spike. If you see one neat spike, just like is seen on SPEP for M protein in patients with multiple myeloma, you see a picture very similar in MALDI-TOF as well. Now, Mayo Clinic had very nicely shown the ranges. So if it is kappa, then there is a range, for mass to charge, and there are different charge states. There's something called M plus H and M plus 2H. For kappa and lambda, very nicely defined. And all the work so far was on IP, immunoprecipitation. So you're looking at antigen-antibody reactions. Some work had, of course, there was work that had come out from other parts of the world. There was work from the UK, from Mayo Clinic, from, of course, Dr. Ashutosh Vechlekar's group in London. And it was very interesting to see that the concordance between MALDI-TOF by peripheral blood and bone marrow was 62% at that time. Of course, now things have evolved and the percentages have gone up significantly. I won't go into detail on the protocols. This is what we did was we worked on the Mayo protocol with the reagents that were available in the country, and we did the same antigen-antibody reaction. Little antibody you get, and the cost is immense. So we chanced upon this astronitrile precipitation. The protein looked very, very stable, and my colleague, Professor Gopal Gopishetty in the lab, who runs the proteomics facility, who leads the proteomics facility, had a discussion. The three of us had a discussion, Dr. T. Rajkumar, my PhD guide, and Dr. Gopal and I. And what Dr. Rajkumar said was the protein appears stable. So why don't you use that same astronitrile technique and let's see if it works for M protein. And it did work. So what you see over here is healthy controls. We got samples from the blood bank, and you see that nice Gaussian distribution. And what you see on the right is multiple samples superimposed over each other. So we defined our ranges, and we were able to show that lambda and kappa did fall, by and large fell within those ranges. Now this is essentially an image of how it looks for someone who has a positive M protein. What you see on the left is the astronitrile technique. It's just a chemical. And at the institute, we get chemicals for free. So all we did was we added 50% of astronitrile, we precipitated the protein, and then we washed the supernatant with 20% of acetonitrile. And then the results seemed quite identical. And what you see on the right is the Mayo Clinic technique, the modified Mayo Clinic antibody immunoprecipitation. So the previous example was a kappa monoclonal gammopathy, and this one is a patient with lambda monoclonal gammopathy. Of course, we picked up the M protein in samples with MGUS. The number of samples of MGUS and smoldering myeloma we get are a lot less at the institute. This is a picture of the glycosylated light chain. We did have a discussion with Professor Murray, and he wanted me to show him images on these glycosylated light chains. So they look a little different. What you see is there's a rightward shift, and you see these polytypic peaks. And I told him how many we'd seen in that entire sample set, and he was happy to note that we did pick up glycosylated light chains. This is a sign of in MGUS, if participants have glycosylated light chains, there's data to show that they are the ones who can progress to myeloma. You also see this in amyloidosis. This is another example of amyloidosis. This is an example of a patient on daratumumab. And as we know, daratumumab is an IgG kappa monoclonal antibody. So of course, the regular SPEPs and the IFEs might be a little misleading unless you have DARA, which is that DARA IFE reflex assay. It's a little expensive to have that. This is certainly one of the very good ways of following up these patients, because there's a specific molecular weight for the M protein and a specific molecular weight for daratumumab. And it's very, very rare that you'll see both merging. That's an extremely unlikely scenario. And we did publish the results in 2020 of the low-cost methodology. This was, what we published was a data set on 202 samples. Most of them were with multiple myeloma or other plasma cell dyscrasias. The sensitivity was 98.3%. The Mayo Clinic study also has quoted a sensitivity of 98%. However, our specificity is low, it's only 52. And that's because the gold standard over here that we used was IFE. We were outsourcing the IFE. So we could not do serial dilutions. We could not really control that component because we were paying for that test. And it's possible that some of those IFEs were negative when they actually may have been, if you did serial dilutions, you may have picked up some more positives. This is just to show some data on quantification of MALDI-TOF. We have only developed a qualitative assay. The IMWG has clearly mentioned that this should be adopted, that we should look at its use prospectively as well. This was some work we wrote in the Lancet Hematology. It was an editorial where we talked about the importance, as Professor Uday Yanamandra talked about, low-cost diagnostics. We essentially talked about this for LMICs. We subsequently initiated a study this year. A generous grant was provided, a CSR grant, for the prevalence of MGUS in Tamil Nadu. This is a population-based prospective cohort study in Chennai, Tirunelveli, and Tenkasi. And we initiated the study in Feb 24, but for several reasons, we were able to start the study only in August. The sample size is 4,100. The prevalence that's known above 50 years of age from studies abroad is anywhere between 3 and 5%, and we calculated it accordingly and came to this sample size, accounting for a 10% fallout from the study. And I'm happy to inform you that we will complete the sample collection in a few days. We're about 100 samples away and a couple of camps away. This has honestly been the most heartening activity. We went out into the community. It was really exciting, different challenges every single day. But we got necessary clearances, which is why we did not run into any major issues. These were issues that could be tackled, but they were members from the community. There were women's support groups, there were males that, groups that came together, religious groups across religions. On Sundays, some groups preferred to have the samples collected. On Fridays, some of them preferred it, and on other days. We had police officers, Manrega workers. They were all happy to contribute. And of course, we very clearly told them that this is a pre-cancerous test, and of course, we tell participants very clearly that only 1% will go on to develop multiple myeloma, and detailed consents were taken. This is my concluding slide. I'm incredibly grateful to the Sanmar Group for having provided the CSR grant. Of course, my super mentor, Dr. Vincent Rajkumar, I think sir is not here. The group that we developed the MALDI-TOF assay, Mr. Subramani Jayavelu and Dr. Gopal Gopi Shetty from Molecular Oncology, Dr. Parth Shah, he's at Dartmouth and also serves as an advisor for Newburgh. And we've done a lot of the other blood tests for the epidemiology study along with Newburgh labs. The biochemistry team, we went out into the community with the Department of Psycho-Oncology. They have a great field presence. We're incredibly grateful to the government of Tamil Nadu. We collaborated with the Directorate of Public Health and Preventive Medicine. The epidemiology component with Professor Manoj Murekar and his team. He is the director of National Institute of Epidemiology, ICMR, Chennai. Incredibly grateful to Mayo. And another component, a research component, is with Professor Pramod Vangekar, who's at the institute at IIT Bombay in the Department of Chemical Engineering. Very grateful to Dr. Prashant Ganeshan. If it wasn't for him, he's presently in the department in JIPMER in medical oncology. If it wasn't for his push, I wouldn't have met Dr. Vincent Rajkumar that day because I was actually standing in for him. He couldn't come that day. Dr. Vikram Matthews, I wouldn't have completed any of my research work without his guidance, without his constant support. Shanta Madam, lots of promises to keep. She knew everything. She's gone over all the letters, all the communications between Dr. Vincent Rajkumar and me and how we were planning this project. And last but not the least, Cancer Institute WIA. This is where my heart and soul resides. This is my first home. And this is my last presentation as a faculty member of Cancer Institute WIA. I'm incredibly grateful to the administration and every member in the institute. The project will go on for 2 more years. The sample collection is done, but there is a research component and the papers and, correlating between the tests and the MALDI-TOF validation that's ongoing in molecular oncology. So we've been able to, I will continue taking care of that project until it reaches its logical conclusion. Thank you. Thank you once again.
Thank you, ma'am. We can discuss on one question. So no question. Thank you, ma'am.
Thank you.
So next speaker is Dr. Hari Menon. Sir will discuss a BCMA-based CAR T-cell therapy, data from the India.
Thank you. So it's good to heartening to see that towards the last talk. I think this is the last talk, is it? One more is there, sorry. Okay. So Yeah. Okay. Okay. First of all, I would like to thank the organizing team, Reena ma'am and Image, for allowing us to present this important data. And it is heartening to sort of present this data because it is something that we have been looking forward to and hoping for its success always. So can we have the first slide, please? Yeah, thanks. Yeah. I'm presenting this on behalf of Origin Oncology and also the team and the multiple sites which went into the designing of the study primarily, and then getting it into functionality, and with a lot of discussion which went into how the protocol has to be developed over here. So this is the phase 1/2 study, open label multicentric study to evaluate the efficacy and safety of DRL 1801 in patients with relapsed refractory multiple myeloma. And the data cutoff was 25th December 2024. So I'm presenting the phase 1 data. We have embarked onto the phase 2 data, the phase 2 part of the study just this month, with the first patient being enrolled into the phase 2 study. So DRL 1801 or Rebrecel, or Rebracaptogene leclusil, is a second generation CAR T cell, and as is looking at the structure, it has an antigen binding domain, and specifically I would pay attention, draw your attention to the nanobody against which the BCMA binds. It has, as is typical of any CAR T cell construct, there has a linker spacer which is CD8 alpha, a transmembrane domain. A co-stimulatory molecule is a 4-1BB, which is one of the common ones used in the other CAR T cells, and also the signaling domain is the CD3 zeta. So I just draw attention to the nanobody aspect of that, which is again something that is associated with cilta-cel, but not with idecaptogene. But what I need to talk about is the antigen binding domain is part of the variable domain of the heavy chain, which is actually derived from the variable heavy chain, which is usually seen in the Chlamydia family and in sharks actually, and this has been modified and humanized through amino acid redistribution. And the importance of this nanobody domain is its ability to bind with the BCMA target more efficiently. So it has these fingers, as we call it, called the CDR3 region, which can move into the crevices of the BCMA, which is the target over here. So this is something that is there with the cilta-cel, which we know about, and it has been used in the Rebrecel also. So as I said, the homology model of CAR T cells having humanized B77 nanobody is one of the characteristics of the Rebrecel CAR construct. And another aspect of the Rebrecel was the way that it was manufactured. There has been modification in terms of improving the expansion of the CAR T cells in a more effective way, and that is using the Gatherex pump, which is what I would see at the bottom over there. Can I have the so the Gatherex pump, which is actually a silicon main membrane which allows for the diffusion of the gases in a more uniform manner when we are manufacturing the CAR T cells. And what is that translated into is a better expansion of the CAR T cells in this medium as against the usual expansion using the bags over here. So we have, although the other parameters is essentially comparable with those manufactured, but the T cell expansion is significantly better using this technology. So it went through the preclinical efficacy for Rebrecel was done in animal models, and what was demonstrated was that the survival in mice was improved when we use the CAR T cells over here as against mock T cells, and also when you looked at there was a small correlation between the concentration, the amount of the concentration of the CARs used over here, but uniformly there was a response which led to tumor regression in the animal models, and there was it was in a dose-dependent manner. So, following this, we embarked on this study, which was multicentric, including 7 centers, and it was the whole is manufactured at the GMP facility with Origin Oncology, which is being supported by Dr. Reddy's laboratories, and these were the 8 patients that we recruited onto the study. One from CMC Velo, another from Hyderabad, 2 from our center, St. John's Medical, and 2 from Sidecare Cancer Hospital, and one from Fortis Hospital. And if you look at the distribution of the patients, they were equally distributed among. There were 4 females included in this, and 4 males over here, and also most of them were all of them were pentarefractory myeloma patients, and 6 out of the 8 patients had received daratumumab-based treatment. And again, if you look at the distribution, 3 of them were IgG subtype, and 2 of them were IgA. And pure free light chain escape was seen in 3 patients. What is important, all went through the harvesting process, which is just collection of the stem cells where we don't use growth factor support, and the mononuclear cells are collected. And the vein to vein time was on an average about 26 days, which is far less than the time that has been described in the other CAR T cell manufacturing process, which was an average of 42 days. And what we, in terms of, we gave uniformly all patients lymphodepleting therapy with fludarabine and cyclophosphamide for 3 days, followed by the infusion of the CAR T cells. Fortunately, as was described in the other CAR T cell studies also, there was hardly any cytokine release syndrome except for probably grade 1 in about 6, and that was manifested in the form of fever or in the transient rise in the interleukin 6, which was used as one of the parameters to see whether there is any suggestion of CRS happening over there. And the ICANS, if at all, was seen only in 1 patient, and which was again transient, which lasted for a day. And neutropenia was predominantly as a result of the lymphodepletion therapy that we were giving, and we encountered grade 3 in about 75% of the patients, but they were transient. And again, thrombocytopenia and lymphopenia in these patients. Infection was never documented in any of the patients at the time or around the time of the CAR T cell infusion, but there was 1 patient who subsequently developed several months down the line infection, from which the patient is currently recovering. The upper respiratory tract infection, which was really not identified as any particular, and was a clinical was about seen in about 2 patients. So the severe adverse events, I said this was only in 1 patient who had presented with dengue fever and who had received 7 previous lines of therapy, and he had presented with a lower respiratory. It's the same patient also subsequently presented with a lower respiratory tract infection, and thereafter with a calculus cholecystitis, and also developed secondarily developed intra-abdominal sepsis, was treated conservatively, and currently is recovering from that. So. So this was presented by Biju in the morning. This is the first patient which was recruited at CMC Vellore, and this was the same patient we're talking about in the case discussion, which was a gynecologist, wherein there was the patient had received almost 5 lines of therapy. They were primary progressive disease. And these were the lines of therapy: CyBorD, VLD, daratumumab-based autologous stem cell transplant, relapsed post BMT, and also was put on salvage therapy progress. So almost 7 lines of therapy in these patients. So this was the pattern of at 10 months at the time of infusion with the CAR T cell, and subsequently there has been sustained responses, which is almost now it is complete. Vikram and his group were, recruited this patient in December. We recruited our first patient in January, and pretty much the same results that we have encountered. I can vouch for that because I have access to those results for the patients, and all of them were pentarefractory, and all of them have had a steady decline, and all of them have actually become MRD negative too. So when we talked about the overall efficacy parameters over here, it did not matter about the dosage that was required, but we stuck to at least delivering about 5 × 10⁶ CAR T cells per kg, and 4 of the patients received that dose, and 4 patients received 10 × 10⁶ CAR T cells. And the overall response rate was 100%. 1 patient had partial response, and 7 patients had a CR. And on follow-up documentation, as we used to do the day 100 MRD status in these patients, and 6 out of the 7 patients in CR had achieved an MRD negative status. Kunal's lab did the MRD assessment in this trial. So when we look at the pharmacokinetics of by dose, we generally saw that the CAR transgene number was comparable depending on whether it was the dosing was 5 × 10⁶ or 10 × 10⁶ cells per kg. And what was important to identify that we could recognize these CARs for the first for the first 4 weeks to 6 weeks, and after which there was a steady decline of the CAR T cells at 60 days, actually. So there was no demonstration of the CAR T cells on the assay beyond the 60 days time point in all these patients. So we also looked at the quality control in terms of the CD3 positive cells, the CD4 CD8 ratio, and viability post-freeze and the thaw of these patients, and also the CAR gene copy numbers, the cytotoxicity, and the CAR T cell expressions, and all were excellent in terms of the outcomes. And the T cell phenotype, whether it was in all the patients we looked at, and this is the distribution that we saw among the naive, the central memory cells, the effector memory cells, and the effectors over here. So when we just made it, even though it's this is a small study, we are comparing 8 patients with almost 100 patients in the Cartitude and the the idacaptogene and the cilta-cel group, and but if you look at it, the efficacy was very much comparable. The complete response rates initially was far better, almost 87% in this group over here, with the overall response rates, which were, in our group, only the 8 patients, overall response rate is 100%, with 6 out of 7 patients achieving MRD negative status. So the last patients on the study has completed now 6 months of treatment, 6 months on follow-up, and they are doing well. So we have embarked onto the phase 2 part of the study, and the first patient was enrolled and was just discharged 3 days ago, and he also had grade 1 CRS, which was again documented by a transient rise in the IL-6 levels over there. So in summary, the SWAT study is the first trial of anti-CDMA CAR T cells in India, and the preliminary data from initial 8 patients indicate a single dose of Ribracel has a manageable safety profile without higher grades of CRS or ICANS. I would say none documented so far except for the transient fever and the transient rise in the IL-6 levels. And there has not been any use of tocilizumab in any of these patients, and all patients responded at the first analysis with CR in 7 out of 7 patients. And there does not seem to be any relationship between dose versus pharmacokinetics, the safety and efficacy. And the phase 2 dosing has started on the first on the patient now, and we intend to recruit another 16 patients on the phase 2 study to complete the study. So thank you, and thank you to Origin to bringing this technology into India, and I'm happy to have presented a positive outcome, and we hope that that sustains over a period of time. Generally, when we're looking at CAR T cells, if they have had a response for about a year sustained, then they tend to have a response continued. Most of the failures happen within the first 4 to 5 months of treatment. Thank you. If there are any questions. Yeah.
Thank you, Hari. Hello. Thank you. I think there could be 1 or 2 questions. People have been awed by your results, 100,000.
No, I always you get that things even, but we have to wait for the long-term outcomes. Yeah. Nikita wants to.
Yeah, Nikita, you can ask.
So fantastic presentation. So of course the phase 2 is ongoing now, but from the few patients that have been treated and the trial is ongoing, how do you see this placed in the present armamentarium, at least in India, in the first relapse or much later?
So, the study as such allowed for patients who have failed 2 lines of therapy. Yeah. So at the time of second relapse, it was allowed for. So, but it's a different matter that we took all patients who were penta-refractory over here. So I think that when it comes to the point, I think it would be it would be a strategy to probably use it after 2 lines of therapy is over, because of failed 2 lines of therapy. And the cost is going to be a factor, because the virus, the lentivirus which is being used is an imported one, and that is where the cost actually comes up. But they are trying to trying to place it in a reasonably affordable range for the patients. But I'm sure that with the other, there are 2 other, Immunil and ImmunoAct are also launching their BCMA CAR shortly, and I think with that it would come. But the most important thing that we have to understand is the CARs, the efficacy of the CAR, and how much of binding it has, and also the sustenance of the CARs. Contrary to what has been demonstrated, the longer you have a sustenance of the CAR in the system, the better is the efficacy of the CAR. But that we have not actually seen over here, because by day 60 we are not actually seeing any of the CAR in the pharmacokinetic study. So, but the fact remains in the proof of the pudding, because you're seeing the results which have been sustained in all the patients, except for 1 patient who is in partial response. All of them are maintaining the responses. Yeah.
Thank you, sir.
Thank you.
But it is going to be, there's going to be challenges in terms of the cost. Yeah.
Yeah. So people can refer patients to those centers you have already mentioned. Thank you, Hari.
Yeah, thank you.
And now we come to the last talk, which will be given by Nikhil, Dr. Nikhil Patkar. Again, who does not need any introduction. Clinician, scientist and professor, Hematopathology Laboratory, Tata Memorial Center, who is also a Wellcome DBT Intermediate Fellow. Over to you, Nikhil.
So thank you. At the outset, I'd like to thank Dr. Reena Nair, my teacher, Dr. Mishra sir, and my colleague, Dr. Mayur Parihar, for inviting me to talk on the use of next generation sequencing in plasma cell neoplasms, my experience with this so far. So, we are constantly fighting infections which are produced by antibodies by normal plasma cells, and you can see how these plasma cells develop when there is exposure to and known to any of the antigens that is there. They stimulate these B cells to form centroblasts, which form memory B cells and plasma blasts. These plasma blasts undergo something called as class switch recombination, and they develop high affinity plasma cells. So, myeloma results almost always as a result of errors in class switch recombination. So there's an enzyme called AID, which is called activation-induced cytidine deaminase, which causes mutations of the immunoglobulin heavy and light chains. And during class switch recombination, class switch recombination then occurs by recombination of regions resulting in a new IGH region. So this is very important for forming very specific antibodies to fight infections, immunity, or whatever. But at the same time, this results in errors, and this results in this recombination sometimes, very rarely, occurs with other regions which are not supposed to occur, and this results in translocations. So multiple myeloma, for this audience, needs no introduction. It is preceded by asymptomatic stages in virtually all cases, MGUS and smoldering myeloma. So there are criteria. The new WHO classification states that you have plasmacytoma, you have myeloma, and there are clinical variants in this which are smoldering, non-secretory, and plasma cell leukemia. So what are the genetic abnormalities in myeloma? The most common genetic abnormality that we see are copy number alterations. Then we have chromosomal translocations. Then the presence of somatic gene mutations, and lastly, clonal VDJ rearrangement. So if you look at copy number alterations, these are not at a gene level, these are at a chromosome level. So most commonly you have hyperdiploidy, which is a high number of chromosomes between 48 to 74, and you can have trisomies of multiple chromosomes, and these are actually an primary genetic event. So if you see the origin of these genetic events in myeloma, the hyperdiploidy as well as the loss of chromosome 13 or 13q and various immunoglobulin heavy chain translocations are actually early events, and then somatic mutations and some more abnormalities like deletion 17p occur more later down the line. And nearly half of MGUS and multiple myeloma are hyperdiploid, and they overlap with other abnormalities. So it's not that these are random, they are actually commonly seen in myeloma. For example, deletion 13q occurs in nearly 45%, gain of 1 occurs in 40%, and at varying frequencies, and these have prognostic relevance which are used to form these the recommendations based on which multiple myeloma is risk stratified. Chromosomal translocations occur at the 14q32 locus, seen in nearly 40% of patients, and these are the IGH locus here gets translocated with various different partners. So you have CCND1, CCND3, and they have varying incidences of 20%, 5%, 10%, and they have different problem. So how do you detect these abnormalities? If you want to detect these abnormalities, IGH translocations are seen in in a lot of hematological malignancies. So in hematology, you see them in PH like ALL, for example, IGH CRLF2. You see them in myeloma. You see them in B cell lymphomas such as CCND1, BCL2, BCL6, and you cannot. If you've realized, we never order an RNA test for these fusions. The reason is these occur at a promoter level. they do not necessarily result in a fusion partner. So you never do RNA sequencing for these fusions, because you are not going to find anything except other than genes that get overexpressed. So they occur at a promoter level, and this is an example of something that is known as enhancer hijacking. So it's one of the phenomena that's described in various malignancies, especially in hematological malignancies. So you know, some of them, for example, IgH, EPOR, IgH-DUX4, we see them by doing transcriptome sequencing. You also have somatic mutations in myeloma. There's a huge laundry list of mutations that occurs, but most importantly, the only mutation that matters or is known to matter in myeloma is actually the presence of TP53. So with almost all cancers, hematology or otherwise, we know that there are two kinds of TP53 alterations that take place. First is a chromosomal alteration, which is a deletion of 17p, which we detect by FISH. The second is a TP53 mutation. So if both of them occur together, and this is across the board for all cancers, AML, CLL, and of course myeloma as well, these have a worse outcome. There's a third event that occurs, which is known as copy neutral loss of heterozygosity. When there is a mutation, there is a deletion, that deleted arm gets duplicated and you miss it by FISH, but it has a terrible outcome. So biallelic TP53 mutations in myeloma are worst. There are also VDJ gene rearrangements. Unlike CLL, where a patient may be unmutated or mutated for IGVH mutations and have different prognosis, this is not the case in myeloma. All myeloma will be IGHV mutated, and it has no prognostic relevance. The main goal of doing IGH sequencing is to identify a dominant clone, which can then be used for IgTCR monitoring. So why do we require this new test for myeloma? This is something that is not being done in the community routinely. There are, I'm trying to build a case for it. So if you see, for CNV detection, typically there is one FISH panel. If you want to do translocation on that, there is another FISH panel. If you want to do TP53 mutations, you have to do a molecular test. And if you want to then do, MRD by NGS, then there's another molecular test. There's enough evidence for each of these, tests that by itself you need this at a clinical level. So NGS workflow promises one test across for this. So how do people go about this? Is that there have been studies that have published. There's an excellent review in Clinical Cancer Research on targeted NGS assays in myeloma. These are large assays, and typically these are assays that can detect somatic mutations, copy number alterations, as well as structural variants involving the IG locus. All right, so we can just see. So what we did to design such an NGS assay is to develop a combined assay which can detect all of these things at one time. So to detect genome-wide copy number alterations, we have 3,000 probes which are distributed based on single nucleotide polymorphisms that occur commonly in European and African populations, and these probes are equally spaced all over the genome. So they give you something like a digital array or a SNP array which can help detect chromosome losses or gains. For translocations, we reviewed literature for all for translocations on all IGH loci, and these were used to design a sort of a hotspot panel. So these fusions are there which can be detected, which can cover all of these. And then you have VH gene rearrangements which can again be detected by a capture-based panel. And lastly, the somatic mutations, we just focused on KRAS, NRAS and TP53 mutations. So all of these probes were combined together to make one myeloma panel. So how do you detect these copy number alterations? One method to do this is by doing something known as depth of coverage based approach, wherein you sequence that genome and compare that coverage for that genome with a normal genome. And if you see that there is a gain or a loss of coverage, you say that something is lost or gained, like a deletion or a duplication. You also have a phenomena for copy neutral loss of heterozygosity. It's a technical thing, but every allele has got a B allele and an A allele depending on the two chromosome arms, and if these are altered, you can say that there is a change in the B allelic fraction. So let us see some cases on how this is actually done in for clinical use. So this is how a normal CNV plot looks like. This is the genome-wide CNV plot, and these are all the different chromosomes, and you can see that this is the normal CNV plot for this. There's a whole lot of bioinformatic tools that are used to derive this. I'll not deal with this, discuss this. A 44-year-old male, 18% clonal plasma cells on flow. The fish shows hyperdiploidy. What you can see here on a CNV plot is that this patient shows gain of multiple chromosomes. The stuff that you see here in the stuff that you see here in yellow shows a gain of 5, gain of 3, 5, 7, as well as a higher gain in chromosome 9. So there are multiple gains of chromosomes detected both by fish as well as by genomics, and you can see that there is in addition a KRAS mutation. So this has a favorable prognosis myeloma. In addition, we can also identify what is the dominant clone, and you can see that there is one single clonal peak that is detected. There is another patient here which shows 1q amplification and a 13q loss, and this is seen by fish as well as by NGS, and you can see that these patients have an adverse prognosis. You can see that in this patient for chromosome 13, the B allelic fraction is completely skewed, and it shows that this is abnormal. All right, and this shows a single clonal peak of plasma cells for this region. So this is again again another case where you can see that there are multiple abnormalities that are detected here. Gain of chromosomes, there is a loss of some chromosome, and a 1q amplification that is seen. As well as this. So similarly, you can have multiple abnormalities here. But now let us look at this case. On fish, you have a translocation 614 here. And you can see that on NGS, this is how this looks like. So you can see that this read applies to, this read has mapped very nicely to chromosome 14, but in addition, it has another partner here which is unidentified. So this is, you can say that this is, if you map this and annotate it, you can identify the IGH CCND3 translocation. So this is how it looks at on a more closer level. You can get sequence level information which can be used for further testing. This is another patient where you can identify translocation 1114 based on these NGS assays. This is the read level data that is there. Another patient, 66-year-old male, which has got multiple deletion 13q, 1q, 20p loss, and you can have an IGH FGFR3 translocation, which you can see here in this IGV plot. So why do we need this? Look at this. This is a 47-year-old male, 14% plasma cells on bone marrow. NGS is normal, sorry, fish is normal, NGS does not show any abnormalities, but you can see here that there are multiple TP53 alterations detected here. So this is an example of an adverse risk myeloma. And lastly, I have no data of my own for NGS MRD, but you can see here that there is enough number of groups which have demonstrated that NGS MRD for myeloma is a very